Good afternoon. Welcome to the Bogomolets National Medical University, Department of Propedeutics of Internal Medicine number 2. We continue our course of lectures. And I'm VictoriaKhomazjuk, Associate Professor. The topic of our today's lecture is Instrumental Methods for Examination of Cardiovascular System. So we will begin from the simple methods and then proceed to the more complex. First of all, the instrumental method is blood pressure measurement. I hope that you already know how to do this. And as a variant of this may be ambulatory blood pressure monitoring. Next, very important method for examination of the heart is electrocardiography, ECG. It should be recorded at least in 12 leads. And if we want to record ECG for a long period, 24 hours or more, we can use Holter ECG monitoring. Next method of examination is, of course, chest X-ray or chest radiography. Then, of course, we will use a contemporary method of examination, echocardiography, to see the structures of the heart, and also we can use Doppler ultrasound to see the blood flow inside the chambers of the heart, and vascular ultrasonography will help us to see the peripheric vessels. Then, if we are not sure in our diagnosis, we can organize stress testing, so we shall check how the parameters changes during exercise. This exercise may be on treadmill or bicycle, or we can also use pharmacologic tests. Then we can use more complex method and more expensive methods of examination, and it will be magnetic resonance imaging. The abbreviation is MRI, or we can use computed tomography, CT, especially with contrast. And we can use radionuclide studies, perfusion scintigraphy using thallium-201 or technetium-99m to visualize the structures of the heart. All methods that were mentioned above, they are not invasive, yes. But we also, in rather complex cases, can use so-called invasive studies when we will put some device inside of the body of the patient. So, to invasive studies of the heart belong cardiac catheterization, ventriculography, coronary angiography, biopsy of the myocardium, and maybe some others. These studies are invasive. That means that they are rather complex for performing, and also they are maybe complex for a patient. Wow. So we begin from the blood pressure measurement, and I hope that you remember that when you measure blood pressure, first of all, you will use palpation of the brachial artery to see what level of systolic blood pressure does your patient have. And then you make more accurate measurements using stethoscope by auscultative method. And in this case, you can check both systolic and diastolic pressure. You can perform such procedure in one step or in 2 steps, but your first step should be to check the level of systolic pressure by palpation. Why should we do this? Here you can see a picture of the auscultatory gap and explanation of auscultatory gap. Oh, well, so imagine that we inflate the cuff for blood pressure measurement and begin to deflate it. So first we have the first phase of Korotkov sounds. We hear a very sharp sounds. Then will be the period when the sounds are blowing or muted. Then they become softer but once more stronger again, and then they diminish and disappear. So systolic blood pressure is recorded when you begin to hear sounds, and diastolic is recorded when the sounds disappear almostly. So you use first phase of Korotkov and the moment between fourth and fifth phases to record the blood pressure. But if you don't use palpation when you inflate the cuff and you use only auscultation for measurement, you may stop inflate the cuff at this moment. When the sounds become blowing, it is called, this part is called auscultatory gap. And if you stop inflating the cuff here, so the results will be less than real, and the blood pressure of your patient will be underestimated. Oh, well. Next method of examination of the heart, which is not widely used now. This is phonocardiogram, and we record the sounds of the heart work. Now it's not widely used in clinic because we have echocardiography, which is much more accurate and permits us visualize the changes of the valves. But phonocardiogram may be useful for educational purposes and for scientific purposes. Let's remind you how to analyze phonocardiogram. You need ECG recorded simultaneously. At the level of the QRS complex, it will be first heart sound. At the end of T wave, it will be second heart sound. To find third heart sound, or S3, you need to measure this interval between second sound and additional sound. And to find the fourth heart sound, you need to see the end of P wave. Here is phonocardiogram of the gallop. This is normal one, and here we see 2 gallop reads. We speak about this at the previous lecture. One more phonocardiogram with different murmurs which were recorded at the apex. This is systolic murmur of the mitral insufficiency, and here we see diastolic murmur of the mitral stenosis. Next variant of instrumental examination of the heart is called polycardiogram, because we have here ECG. We have also phonocardiogram, which was recorded at the left sternal border, and at the same time it was recorded jugular venous pulse. Using such polycardiogram, you can analyze the phases of the cardiac cycle. Next variant, we can see the recording of different pulse. In the upper part, there is recording of jugular pulse, and such recording will be called phlebography. And in the lower part, we see the recording of the carotid pulse. The recording of the carotid pulse is called sphygmography, or sphygmogram. Well, and let's look. During ventricular systole, we see a high wave of carotid pulse. Yes, so the carotid artery, if we palpate it, we will feel the pulse wave. But at the same time, the wave of the jugular pulse is negative. It means that at the moment of systole of ventricles, the jugular veins are empty. And this is normal, and this is called negative venous pulse. But if we see the next picture with pulsations, we see that in the case of tricuspid regurgitation or insufficiency of the tricuspid valve, the waves of carotid pulse and venous pulse are at the same time. Such pathologic phenomenon is called positive venous pulse, and we can see at the neck of the patient that the veins are filled during systole of ventricles. It happens because of the retrograde blood flow through the insufficient valve from right ventricle to the right atrium and back to the jugular veins. Oh, well, next method for examination of veins is invasive. You should know that to measure the venous pressure, we need to use invasive study. We need to put a catheter inside of the vein. There are no not invasive methods for this, only observation. But if you want to receive some figures of the venous pressure, you should use invasive study, and we have two values. First of all, you may check central venous pressure. In this case, you should introduce catheters into the superior vena cava and then to the right atrium. This pressure is measured in the millimeters Gidrargu, and in normal person should be near 0. And you may also measure peripheric venous pressure. In this case, you use brachial or antecubital vein, and you introduce the needle which is connected to the intravenous system filled with fluid, isotonic solution, for example. And you will measure the distance between the level of the heart and the height of the column of fluid in your device, and it will be in the millimeters of the water column. Oh, well, next, we proceed with invasive studies of the heart, and one of them is called cardiac catheterization. This is a diagnostic procedure in which a catheter is introduced into the heart and blood vessel to measure oxygen concentration, saturation, and to measure pressure in the various heart chambers. As you know, in norm, right and left heart chambers are not connected. They are separate. And that's why we have right heart catheterization and left heart catheterization. So to check the pressure and oxygen concentration in the right chambers, a radiopaque catheter is passed from the antecubital or femoral vein into the right atrium then right ventricle, and pulmonary vasculature under direct visualization with the fluoroscope. In all at all these steps, you can measure oxygen concentration and pressure. If you want to check the left heart, so it's usually done by the retrograde catheterization of the left ventricle. So you pass from the femoral artery into aorta, and then through aortic valve into the left ventricle. Oh, well, you can't pass mitral valve in the retrograde direction. That's why if you want to introduce catheter into the left atrium, it can be done transseptally through the interatrial septum. Oh, well, here in the picture, which reminds you the level of systolic and diastolic pressure in different chambers of the heart and the main vessels. Let's continue. The next method of examination of the heart is called coronary angiography. The method is also invasive because we need to introduce catheter at least into the aorta and to the beginning of the coronary arteries, and then put the contrast inside the artery, and we will see the place of stenosis or block, in this case of left ascending artery. Then you use rentgenography to record these findings. This is one more scheme of the coronary angiography. You see that catheter is introduced retrogradely to the beginning of the left main coronary artery, and we can see the place of stenosis, yes, where there is some narrowing of flow through the artery. It may be the cause for myocardial infarction. Oh, wow. One more method for examination of the heart, invasive method, is biopsy of myocardium. It can be done, for example, during a surgical treatment of some diseases. You may take some example of the tissue and then examine it histologically. Here in this example we see the myocardial sclerosis picture. We see a lot of connective tissue in the myocardium. Yes, a lot of connective tissue. We proceed with the next method of the examination of the heart. It is chest X-ray. It's not invasive, it's rather usual. It is used in the all clinics, yeah, and this scheme we should try to I should explain you which part of the heart we will see in the anterior projection. Yeah, so here is the shadow of the heart. We said the shadow for everything which is white on the X-ray. Yeah, and for everything which is dark, we said transparent. So the shadow of the heart on the anteroposterior X-ray, yeah, and if we look at the right border, When we say right, we mean the right part of your patient, not your right, the right of the examined person. So on the right border of the shadow, we see that mostly it is formed by right atrium and a bit small part of right ventricle. Right ventricle is mostly here, yeah. So right atrium, and here is vascular bundle, which consists from superior vena cava and aorta. Here is aortic arch. Oh, sorry. We proceed with next arch on the left side. It will be pulmonary artery. Then we see the small part of the left atrium, and the last arc will be due to left ventricle. So let's look at normal chest X-ray, and you will see here right atrium, yes, here is vascular bundle, and here is aortic arch, aortic nerve on the left, and then here will be pulmonary artery, the arc of pulmonary artery here, the place of left atrium, and here the left ventricle. Look, this was normal chest X-ray, but on the next slide we can see chest X-ray in pericardial infusion, and you can see very large, massive cardiomegaly, enlargement of the shadow of the heart. It is specific for accumulation of fluid in the pericardial cavity, and we can see that the shadow is very intensive. It's more intensive than the usual heart opacity. Oh, wow. And this is the same patient, but we see the computed tomography study of the pericardial infusion. And in this case, you see the level where the section was done on this slide. And look, this is the shadow of the heart chambers, and outside here this is pericardial fluid. On CT scan we can differentiate it. Well, our next X-ray is from a person with aneurysm of aortic arch. You see how aortic arch is enlarged, and here in this part also. Yeah. Well, this is CT scan with iodinated contrast to see aortic arch. We see the section which was done at this level, and here you see very enlarged distended aorta with shifted superior vena cava and trachea rightwards. Why I say to the right? Because it is right side of the patient, not your right. Imagine that you look at patient and it is his right side. Well, next, not invasive method, which is used for examination of the heart, is magnetic resonance. You need a very expensive equipment for this, because you put a patient inside of the magnetic field to record the changes of the heart, but it permits to see not only the outer silhouette of the heart, but also you can see inside the size of the chambers and even movement of blood if it is in the real time. This is the picture of the normal MRI of the healthy person. Let's go on. On this slide, we can see MRI of a person with ventricular aneurysm. This is the cavity of the left ventricle, and you see that it is distended, enlarged, and deformed. It may be due to, for example, myocardial infarction. Oh, well. Next method for examination of the heart, which we will speak about, is called echocardiography. It's my favorite method, and here is the scheme which explains you what can you see at the echocardiogram in the so-called two-dimensional or B mode. Now we are speaking about echocardiogram, which is called transthoracic. It means that you put the transducer on the surface of the chest of the patient. Well, and in this case, you can see the parts, all chambers of the heart. You can measure their size. You can see how thick is the wall, inferior wall or interventricular septum. You also can see the valves. In this case, we see that aortic valve is closed, but mitral valve is open. So can you guess which part of the cardiac cycle is this? Of course, it is diastole. It's diastole of the ventricles, and this is called long axis view because we see section of the heart along its long axis. Here we see also a long axis view of the heart, but it is called apical view because we put our transducer at the apex in the fifth intercostal space, and you can see this view both ventricles, left and right. You see that right is smaller, it's normal, and we see two atria, right and left. And we see atrioventricular valves, and at this picture they are closed. That means that we see systole of the ventricles. Next slide show us that we can receive images not only at long axis but also at short axis at the level of the vessels. And here you can see in the middle aortic valve. It is closed. It means that it is diastolic view. And on the echocardiogram, we can clearly see all three cusps, all three semilunar cups of the aortic valve. This is also normal view. Let's proceed. We proceed with pathology. So this is the echocardiogram of the patient with mitral stenosis, and we can see that mitral valve cusps are thickened and their shape is changed, and we can see enlargement of the left atria. We can see also enlargement of the right ventricle, which is specific for mitral valve stenosis. If we take short axis view of the mitral valve, we can measure the orifice of the valve, and we can see that it is decreased. It is less than 4 centimeters squared. It will be, and it will prove that our patient has stenosis. Next view. Of course, we use not only two-dimensional echocardiography, but we use Doppler effects to see the blood flow inside of the heart. Here we see apical four-chamber view, and we see that left ventricle and left atrium. And when the mitral valve is closed. In systole, we see a retrograde blood flow from the left ventricle to the left atrium. It means that our patient has mitral regurgitation. Here at this slide, we can see the picture of the aortic regurgitation. We see the backflow through the closed aortic valve from aorta to the left ventricle. And this is real picture of aortic regurgitation from the apical view. And if we use color Doppler, we can only see this jet of regurgitation. And the color show us the direction of the jet. But also we can record by continuous wave Doppler the flow of regurgitation and measure its velocity and other parameters. And this is the picture for a left ventricular aneurysm on echocardiography. This is to show you that we can use not only transthoracic echocardiography, but we can use transesophageal echocardiography. In this case, our probe or our transducer will be introduced into the esophagus. And from this part, we will clearly see some view of the heart. Why it may be done? Because in this case, lungs, there will be no lungs between your transducer and the heart, and no ribs, but the air in the lungs and the ribs may not permit you to see something when you use transthoracic approach. But when you use transesophageal transducer, it's better to see back parts of the heart, especially left atria and the thrombus in the left atria. Well, we can use Doppler ultrasonography to see the blood flow in the vessels. In this picture, we see the blood flow in the vessels of the liver. We can also use this for arteries. This is the picture of the carotid artery and the recording of the blood flow in the carotid artery. In systole, we see the peak flow. We can also measure the thickness of the wall of the carotid artery. And this is the blood flow in the femoral artery. You may use color Doppler to visualize this flow, and you may use this pulse wave Doppler to measure the velocity of the flow. Next study, which is used for examination of the heart, it is called stress testing. So you compare the results before exercise at rest and after some physical exercise. The most simple variant is to compare blood pressure and to record ECG at all stages of the exercise. Another variant of the exercise testing is exercise on the treadmill. The patient is walking and you are recording ECG and measuring blood pressure at each step of the exercise. You can also use more complex methods like radionuclide studies. You may use it at rest and after stress test and check how the accumulation of the radionuclides changes and how the perfusion of the myocardium changes after exercise. And here you can see the example of ECG during exercise testing. This is different level of the exercise. The first one is at rest. You see that everything is okay. And after, even at the third step of the exercise, we see that ST segment goes down, and this is the sign of ischemia of the coronary artery disease. Well, and now we shall proceed with the method that you should be acquainted with even at your third year. We will proceed with the electrocardiogram. We will have a lot of practical classes on ECG, and first of all, to understand ECG, you should remind how the conduction system of the heart is organized. Then you should know all the waves on ECG and also be able to measure intervals PR, QRS, and QT. And the next step that you should know and show us will be determination of electric axis. For this, you need to analyze the sum of the waves in the lead 1, then in the lead 3, and then you should build the position of electric axis using the results of your measurement. And this is for lead 1, this is for lead 3, and you put perpendiculars and receive electric axis of the heart, which is in this case something near 52 degrees, so it will be normal position of the electric axis. In Ukraine, we use such positions of electric axis according to the angle of alpha. Angle of alpha, it means this angle between 0 or lead 1 and the electric axis of the heart. So this is angle alpha. And these are the classification of the positions of electric axis that you should know, learn by heart. Well, thank you. This is all for today. Thank you for your attention, and see you soon at our next lectures. Goodbye.